These are my disclosures, none of which are pertinent to what's going on. Now, we think very much in spinal cord injury that, certainly from experimental evidence, that early decompression of both kinetic and static injuries will improve outcomes. And, we've known this for years. And Mike Failings wrote a nice review of this and all the scientific models. And it depends on, what you talk about for early and what, your model is. But there's clear evidence to suggest in the literature that the earlier you can get the spinal cord decompressed, the better the outcome, certainly in experimental animals and experimental spinal cord injury. Now, Staskis actually gave us some evidence, and Tim went through this earlier, that there is greater improvement when you decompress cervical injuries within 24 hours. Now, there's some caveats to that data, and you have to go through it with a fine-tooth comb. But basically, what it was is that you could have more grade 2 and grade 3 improvements in the ASIA scale in patients that were decompressed within 24 hours of their injury compared to those that were decompressed greater than 24 hours after their injury. So the question really is, how's the best way and what's the quickest way to get spinal cord decompressed? And so traction of the cervical spine has been around since really the 1800s. And Crutchfield, developed the tongs in the 1930s, and there have been many proponents since. The problem is you have to really apply the tongs very carefully. You have to do serial exams, and you have to get frequent radiographs. It's something that you have to do under a strict protocol, and you can't do it haphazardly if you want it to work. Now, the problems with closed reduction are that, there are definitely instances of neurologic deterioration. Sometimes you can't get the spine reduced. Now, we had a series from Harborview that we wrote up years ago. Jerry Grant actually was the lead on that. And we collected the data for years. And under a strict protocol and with working very hard, you can get the spine reduced over 90% of the time. The problem is nobody else in the literature can replicate that. So you really have to work hard and have to have a strict protocol to go ahead and provide reduction. In our institution, we work pretty hard to get reduction, but we don't do it nearly as much as we did at Harborview. And our rates of reduction preoperatively are probably in the 60 to 70% range. The other thing is, even once you get the spine reduced, you still need to have some sort of stabilization or an external orthosis. So you haven't completed the process. So a lot of people will say, why not just get the patient reduced under anesthesia and go ahead and then do your definitive maneuvers? And we were talking about that with the last case that kind of showed that as a potential point there. Now, the problem with closed reduction, and the thing that we all fear, is the neurologic deterioration. And this has been something that's been promoted in the literature in sort of very class 3 and class 4 evidence. Nobody really understands what the incidence of disc herniation causing a neurologic deterioration after closed reduction would be. But there's certainly some anecdotal cases out there. Dr. Eismont looked at 68 patients and found that 6 of the 68 patients on post-reduction myelography had disc herniations that needed to be addressed, and 2 of those patients actually worsened during the surgery and woke up worse than they did when they went in. And so the problem was, these were closed reductions, okay, they were open reductions, not closed reductions, and the patients were asleep, and they had a posterior reduction that was done. So, to say that it was absolutely a disc herniation that you could have, identified preoperatively may not have been the case. The paper that really started to get everybody thinking that we should do MRIs more regularly was this paper by Duran. And Tom Ducker was actually the senior author on this. And he said some interesting things over the years, how it actually kind of halted the progress of getting people reduced and so forth and so on. And he said it was almost a very compelling bit of evidence that he didn't necessarily agree with in the final synopsis. But they had 3 patients who worsened during reduction that they attributed to MRIs that showed disc herniations, and that of those patients that they tried to reduce, 10 of the 13 had disc herniations, suggesting that there could be quite a significant number of patients that could worsen potentially if you tried to do a closed reduction as opposed to an open reduction or a discectomy or do a reduction before you identified the problem on MRI. Now, this still continues in the literature. The Journal of Patient Safety and Surgery, which I never knew existed, actually had a recent publication. And this was a gentleman who actually had a bicycle accident. And he endoed over the front of his bicycle. And you can see here he has a C7-T1 fracture dislocation. Now, he's done a posterior laminectomy already. But their point was that if you tried to do an open or a closed reduction prior to identifying this problem on the MRI, this disc herniation, you could have seriously impacted the patient. Now, they did show the gentleman going ahead and getting back on his bike and kind of, saying, look, we took care of this guy carefully. We identified the disc herniation and it wasn't a problem, suggesting that everybody should get an MRI before you do reduction. But the key here was this was a neural intact patient. This was somebody who had a lot to lose if you potentially did something without having all the information, as opposed to somebody who may have been an Asia A who could have had a lot to gain if you went ahead and did the reduction. So what we worry about is deterioration from disc herniation. And schematically, what is shown is that you worry about this disc that could be behind the vertebral body, as I showed on that MRI, going ahead and popping into the spinal canal and causing a problem. Now, there were some papers from Jefferson that were published in the 90s and Rizzoli showed a 54% incidence of disc herniation post-reduction. Alex Vaccaro did a series of patients that had pre-reduction MRIs and post-reduction MRIs and found that about 50% of the patients actually developed a disc herniation post-reduction. And that could be from either bone fragments, disc material, or epidural hematoma that could also cause a sort of ventral compression. The interesting thing in both of these papers, however, was that there was absolutely no evidence or no correlation between the presence of disc herniation and deterioration neurologically. So even though these patients had discs that had herniated or discs that became apparent on the post-reduction MRI, no patients deteriorated neurologically. So closed reduction with a protocol is something that's been published widely in the literature. And there's a lot of papers from the 90s that show, you can do this quite successfully. This is a great series from France of bilateral and unilateral facet dislocations, and they had 168 patients that they went ahead and reduced, and they used a stepwise protocol to achieve reduction. What they would do is they would try a closed reduction with gradual retraction, and they would go up to 4 kilograms plus 2 kilograms per level. If that didn't work, then they would try a reduction under general anesthesia. And if that didn't work, then they'd go through an open reduction through an anterior approach. So this was the stepwise protocol that they went ahead and did. What they found is that using this stepwise protocol, this very rigid protocol that they used, they had no patients who deteriorated neurologically out of a very big series, 168 patients, that none of them had neurologic deterioration with the spine procedure. You can see here that of the bilateral cases, they actually had a fair number that reduced awake and closed, a lot reduced general and closed, and then about a third, or slightly less than a third, had to have an open reduction and anterior surgery to get the reduction completely. But they were able to achieve reduction in all these patients, again, using this stepwise protocol without neurologic deterioration. The series from Harborview that Jens really drove had 82 patients over about a 3-year period of time with fracture dislocations. We were able to get to them quickly and reduce them very quickly within a mean of 2.4 hours after the injury. Unfortunately, there were no dramatic neurologic improvements, though we did have anecdotal evidence previous to this that some patients did, we did have some dramatic sort of saves, as it were. But the thing that was most striking in this is that 80 out of 82 patients, so almost 100%, had successful closed reduction when you worked very hard to achieve this. Now, this is something that, we were all trained to do and something that was very, very important for us. What we did was we did post-reduction MRI in 76 out of those 80 patients and found disc injury in 46% of those patients, but only one patient deteriorated one root level 6 hours post-reduction. So that even though there was a presence of a disc injury in about 50% of the patients, almost none of the patients changed neurologically with this strict reduction protocol. So this led the joint section back in 2002 to show some options for closed reduction. They found that early closed reduction in awake patients is recommended, but not if there's a rostral injury. And then to do the MRI to dictate approach if an open reduction is necessary. In other words, you didn't need the MRI before you did the closed reduction, but if you're going to take the patient to the OR and do an open reduction, you ought to get an MRI to dictate how you should approach the patient. What's come out more recently in the literature? Well, this was a good paper from a group in Edmonton. And what they did was they did 17 consecutive patients, and they reduced them in the MRI scanner to see what happened to the disc, to see if it came out and caused more neural compression or canal compression. They were able to successfully reduce 11 of the 17 patients and partially reduce 4 of the 17 patients. One person couldn't be reduced at all, and one actually reduced while they left him in traction the next day. So they got at least complete or partial reduction in almost all their patients. Of those patients that reduced completely, 11 patients had improvement. 11 patients had improvement in canal dimensions. And basically, 9 of the 11 who had complete reductions had canal improvements, suggesting that when you were reducing these patients and getting back in alignment, you weren't making the canal tighter in any of the patients. None of the patients had a worsening of their canal size on MRI. And what they showed is this is, that's very similar to the patient that I showed earlier. You can see right here, you're worried, what is that? Is that the disc that's back there? Well, the question is it really still contained within the PLL? Well, the previous author that I showed you in that case report would have said that's a disc herniation that's going to get worse. But look what happens as you add weight. The disc actually comes back into the disc space, and even though that's not a complete reduction, I would call that still a partial reduction, the canal size improves and the disc does not herniate into the canal. Other results of reduction, Rydell published 41 patients who had a flexion distraction injury. They were able to reduce over 80% of them. None of them had MRIs, but none of them worsened neurologically with their reduction. And then the group from Jefferson had 45 facet dislocations. Almost 90% of them were able to be reduced with traction, and none of them worsened neurologically, suggesting that you can do a careful reduction and can get improvement in the spinal alignment without neurologic worsening in these patients. So again, John and the joint section went ahead and redid the guidelines just a couple of years ago now, and they said that closed reduction is safe in an awake patient. Overall, if you looked at over 1,200 patients that are reported in the literature, it's 80% successful when you use a careful protocol. And it's very rare for people to have a permanent neurologic sequelae. Only 1% of the patients had permanent neurologic injury after a closed reduction. There was a 2 to 4% incidence of transient neurologic issues, but they could only find 2 case reports or 2 series that had single cases that documented that the worsening was due to a worsening of disc herniation coming into the canal. They did, however, indicate that if a patient fails closed reduction, before you take them to the OR and do an open reduction, you should get an MRI again to dictate your approach. So, neurologic worsening, it seems rare in most of these series, but there are things out there that are published. And to be fair, this is a review from Dr. Tatter, and it shows a retrospective multi-center review. Look at the neurologic injury worsening rate here. So you still have to fight against this, and you still have to make sure you do a careful protocol, because there are people out there who say that closed reduction can cause worsening neurologically, and it has been published in the literature. And the other thing you have to worry about is, of course, over-distracting somebody. You have to do this carefully. This is a patient from the Annals of Harborview, and it's somebody who's already has a distraction injury and somebody who I wouldn't put in traction. Actually, they weren't put in traction, but you can see what happened here when the shoulders were pushed on with this device, emulating sort of a traction device. You can see how there's such a distraction of the vertebral bodies. So you have to be careful about over-distracting these patients, and you have to do traction very carefully when you're looking at these things. Finally, if you have to take somebody to the OR, can you do a ventral reduction? Well, yeah, this has been well published in the literature. By putting your pins in divergent so that you actually, when you put them together, you get a convergent pattern here and actually kyphose the patient, you can go ahead and get the patient reduced. And it's been successfully reported. This was a small series from Ed Benzel. Well, he had 90% of his patients could be successfully reduced intraoperatively when he used these techniques. So in summary, closed reduction without manipulation has little risk when you follow a careful protocol. Now, it's important to remember the risk-benefit ratio in these patients, and we talk about individualizing care for each patient. The trauma services love to protocolize everything, but you just can't do it in spinal cord injury. So your risk-benefit ratio may be low in somebody who's in Asia A or in Asia B, but it's going to be very high in intact patients. So you might want to follow a different protocol, obviously, in an intact patient, and perhaps get an MRI before you do the open reduction. However, it's important to remember that even if when you follow a careful protocol, we published from Harborview that there were 22 patients who were neurologically intact and had no deterioration at reduction. So you can still do it if you do it carefully and if you do it following a protocol without an MRI. So thanks for your attention.